Welcome back to the Chatty Vets Pod. I'm Brendan.
And I'm Charlotte. Thank you for tuning in.
Welcome to our July bonus episode. We thought we'd keep you in suspense for long enough. So it's time for the second part of our chronic pain management series, and we have a very exciting special guest for you.
Yeah, we've been very excited to release this for a while now. We interviewed the amazing Matt Gurney from Zero Pain Philosophy back in March, and we have been too excited to release this for a while now. So I'm very, very glad it's out.
Yes, I think during this interview you'll hear that I think me and Charlotte both go a bit giddy. Don't we?
We go like fangirls. Woo!
Basically, it's true. So yeah, we were planning to talk about a lot more, but we ended up talking about chronic pain for so long that I did ask him at the end of the interview, can you do another one with us? And I think he felt he had to say yes because he was live. But so we did first line. We did subcut ketamine, silencia use, Librela, how harmful it is, paracetamol, amantadine, how to sedate sassy dogs. So yeah, lots of topics.
Yeah, exactly. So we really, really loved our conversation with Matt, and we hope you really love it too. So let's hand over to Matt to chat about everything chronic pain. We hope you enjoy listening. So we wanted to say a massive special welcome to Matt from Zero Pain. So thank you very much for coming on board with us. So if you
Sorry, I had to do that. I couldn't control myself. I've done
Brendan's
that for anyone
been very
else.
excited about this.
I am actually.
So if you can, for anybody who might not know who you are or what you do, if you can give us a bit of sort of a rundown as to, what you do for work, what Zero Pain is.
Sure. Thanks so much for inviting me. I'm as excited as you guys are to be here chatting about pain. Yeah. So my name is Matt Gurney. I'm a specialist in anaesthesia and pain management. I developed an interest in pain management during my residency, and I spend most of my clinical time now is focused on chronic pain management. I really enjoy acute pain management as well, and figuring out the best options from a surgical perspective. And 10 years ago now, together with Carl Bradbrook, who is my partner, he's also an anaesthetist, we started Zero Pain Philosophy. Zero Pain Philosophy is an online educational resource for vet professionals. We decided that we wanted to bring the world of analgesic management to vets, nurses, vet physios, anyone with an interest in pain. And we created Zero Pain. And it is as I say, an online educational resource. We've got webinars, podcasts, pain updates. And in 2024, we launched Zero Pain Practice, which is our accreditation scheme. So yeah, all things pain.
Well, yeah, we saw this, and Brendan was saying about this. So much like how people can be like a cat is like an ISFM clinic, we can now be Zero Pain clinics with you guys. That's really cool.
Yeah, absolutely. And we very much went along the similar approach to ISFM with the self-accreditation approach. You collect your requirements, we set the standard, and the practices submit their case information to us, we review it, and that accreditation lasts for 2 years.
Wow, okay. And is it mostly focused on analgesia or anesthesia, or a mixture of the both? Or
Yeah, so Zero Pain Philosophy as a whole, we focus on acute and chronic pain. Sometimes anesthesia strays in a little bit when we're talking about sedation, because obviously sedation, analgesia, those things go together. And particularly when we think about pre-visit anxiolysis, I've done work for a number of years with Sarah Heath, and we developed some protocols which are on the website looking at pre-visit anxiolysis, because those things all merge together. So we can't help get involved when we're passionate about something in particular.
cool.
Can I going to say, we're going straight into something clinical now, right? Because all of us now do our GABA and our trazodone, and I think melatonin is in there for some of these plans, and I think most of us don't have it. And one of my colleagues said they're getting melatonin for some alopecia case. Should we be getting melatonin in?
It's a good question. It's a big topic. Well, we need to think about what is our outcome with these patients. So is this a dog where we need anxiolysis? Because trazodone and gabapentin, they are anxiolytics. They're not sedatives. And I often think, right, what is your outcome? Is your outcome to get that anxious patient into the clinic so you can give that dog an IM or that cat an IM injection? Then once they're sedated with their IM injection, then you can place an IV, and then you go into your anesthesia. So I think in those stepwise objectives, if this is a dog that is difficult to handle, then we probably need to up our game a little bit, increase our doses, maybe think about the combination of trazodone and gabapentin. Because An anxious dog, I would just start with trazodone with that case and see if we can provide an anxiolytic effect. If we're needing a greater effect, we could combine trazodone and gabapentin, and we might like to give that the night before and the morning of admission in those cases. So I think it's important to think about what we're trying to actually achieve. And it is very rare that we can use enough of those drugs to produce a sedated patient. As long as we can handle the dog or the cat to get an IM injection, our IM drugs are absolutely wonderful. We have the alpha 2 agonists, we've got opioids, we can do wonderful things with those drugs, and they're really effective, they're really quick acting. So they take, I think the thing to think about is that dog that is anxious and wound up, we want to get them from the intervention to sedation and forgetting about what's going on as quickly as possible without having a go. It doesn't work. The dog gets stressed. We get stressed. We have another go and it just escalates and gets much worse. Melatonin, okay, I think it's in a chill protocol they call it the chill protocol in the US. It's not widely available in the UK, and therefore I kind of say I probably wouldn't worry too much about including it. I think what's more important is that we think about what our objectives are with those patients, and we think about our dog friendly handling, because half the time we're trying to do it in. I look around all the places I've worked in, noisy places, they're busy places, they're not ideal for trying to deal with these dogs. So I think a really big thing is to step back and think, right, how can we do this the best way possible in the surroundings that we have available to us?
Feeding into that a little bit, when you're talking about these, because I think as ever since lockdown as well, we're seeing these super anxious patients all the time, right? They're coming in through the door every
Mm,
day.
yeah.
Do you tend to, I know again, this is probably going more into sedation protocols, etc., but a lot of people will use benzos in part of their sedation protocol as well because they're wanting them to not really remember things and to think, okay, once you've given that injection, they chill out and hopefully afterwards it makes recovery a bit nicer. They don't remember quite what's happened. Are you on board with that as well? Sort of zero pain thinks along the same?
Yeah, so the theory there is that in people, benzodiazepines have a retrograde amnesic effect. So yeah, we just forget what happened. In dog, okay, we don't see any reason why that wouldn't be the case in dogs and cats. I think what we've got to think about is how we use it. It's always the how with drugs. They do what we say. They do what they say they're going to do, as long as we use them in the right kind of way at the right kind of doses. There's a really interesting study looking at sedation in healthy dogs with medetomidine and midazolam, or just medetomidine on its own. And in the just medetomidine group, they got better sedation.
Really?
Because we're always taught, aren't we, that benzodiazepines, they're great for young patients, they're great for old patients, they're great for sick patients. But in our fit and healthy patients, you can get disinhibition. And what you tend to find is if you give that IM injection with all three, I say all three because I'm thinking medetomidine, midazolam, and then your opioid. Sometimes the midazolam hits first, and that can just make those dogs a bit twitchy, a bit, all of a sudden your listeners see me kind of bobbing my head
Yeah.
around. It's hilarious. I was on video doing funny. Anyway, sometimes you do get that effect. I think yes, when you incorporate a benzodiazepine, it works really nicely. You get you get a beautiful sedative effect with them. The other way we do often use the benzodiazepines if we've got a mildly anxious patient, we've been successful with our medetomidine and our methadone or our butorphanol IM, we can use it as a co-induction if we're inducing anesthesia. Or what I will tend to do if we're just sedating those patients is wait for the medetomidine and the opioid to take effect and then give them midazolam. Because once the alpha 2 is on board, you're not going to get that inhibiting effect. Sorry,
Yeah.
spit my words out.
Yeah.
Yeah.
And I was only going to say on the benzo side of it, I know one vet, so it was a really good vet. She said to me a couple of years ago, we were all using too high a dose on our benzos, and we should be using like a quarter of the dose. So I started, and like some of that kind of where they go the wrong way and they start acting all jittery. So I started on a quarter, I think 0.3 mg per kg for diazepam, I guess, and I was using a quarter of that dose. Is that a little niche idea?
I'm just trying to rack my brain. I don't think I've ever seen a study that uses different doses of midazolam or diazepam. We are very predictable in our 0.25, 0.3, 0.5 mg per kg of midazolam. Quite interesting. One of the things we did a study a few years ago when alfaxolone was launched. Obviously, people think about using the benzodiazepines alongside our induction agents to reduce the dose of the induction agent in a co-induction fashion because it prevents all the nasty things we think about with our induction agent. Although, to be entirely honest with you, there's not very much nasty about propofol and alfaxolone, if I'm honest. We did a study, we compared one group of dogs that they had an acepromazine methadone pre-med, then they were induced with alfaxolone, or they had a co-induction with midazolam. And we saw more post-induction apnea in the group where we included midazolam compared to alfaxolone. So yes, that was an interesting point there. So, I mean, my question sometimes is, do we need to co-induce? Okay, yes, it's brilliant for those anxious patients if we want an amnesic effect, but do we always need to co-induce? Are we really worried about how much propofol or alfaxon we're giving these patients? I'm not really worried about it.
I definitely created an apneic patient when I was my boss was doing the surgery, and unfortunately we didn't have a nurse, which is a dangerous thing. And so I was doing the anesthetic, and I thought, oh right, just give a little bit of diazepam because apparently it's not respiratory depressive, it's not cardiovascular depression. I thought I'd spare my eyes a flow, whatever. I put some in. Patient stopped breathing and didn't recover breathing. So I then had to manually ventilate for about 25 minutes while my boss was operating. So there we are. So I think that's not true, is it? It's not, or is it?
I think what is true, it has minimal cardiovascular depressant effects. Cardiorespiratory, no, absolutely not. You're absolutely right. If you've got a dog that's anaesthetized and you give them 0.3 mg per kg of midazolam or diazepam IV, you're going to see apnea, definitely. Yes,
No.
in my experience.
Sorry, my boss is watching.
There'll be someone who just listens to this saying he's talking rubbish, but no, in my experience, yeah, you get respiratory depression with a benzo. No drug is 100% safe or
No,
innocuous.
exactly.
No safe drug.
One thing I did really want to bring up with you, Matt, to see your opinion on it. We chatted in one of the episodes previously about the use of subcut ketamine in chronic pain patients because
Mm,
I've started to use it a lot more in
yeah.
my anesthesia protocols. I find it is really good as a rescue analgesia, etc. But are you guys recommending it quite often in your chronic pain management cases? And, which ones do you think it's really good for? How often are you using it? Because I know sometimes people talk about it monthly, and potentially even going to weekly if you find that they're responding well, but they're getting more painful as the disease progresses.
Yeah, so the story started, I think it was 2012 when I first used it in a patient that had lumbosacral
Hmm.
disease. And this was a dog before the days of epidural steroids. This dog was treated with all sorts of analgesics and wasn't comfortable. And the orthopedic surgeon said to me, look, have you got any ideas? So I had a chat with a friend of mine who I'd worked with at Liverpool, Dr. Izzy If, who is now in Bern. And we had a chat and we thought, okay, why don't we try some subcut ketamine in this patient? And we we found a dose in the literature from a human perspective, which was half a mg per kg, and we thought, okay, let's give this a try because the dog has had all of the current options. And bearing in mind at that time, I think it was 2009, there was a case series published on the treatment of neuropathic pain in 3 dogs, and that was published in the Australian Vet Journal. There wasn't a lot of information around about treating neuropathic pain at that time, and it was the same year as Sarah Moore published a review of managing neuropathic pain in dogs, which I think if you look for a review of managing neuropathic pain, that's the one that most people come up with. And that review didn't mention subcut ketamine, by the way. So we tried this. This dog belonged to the client worked as a veterinary receptionist. And we said, okay, let's see how effective this is. And we used her own outcome measures. So what we'd now call caregiver reported outcome measures. So 3 to 5 behaviors that you associate with pain or things your dog has stopped doing since they've been more comfortable. And we found that was effective for up to a month in that case.
Yeah.
And it was definitely over a year where we treated that dog on a monthly basis. I think it was around about the 18-month point that she called and said, look, I think he needs it more often. And we started every 2 weeks. We just increased it to fortnightly as a
Mm.
frequency. And then I think it was another 6 months and his pain got worse during that time. And we increased the ketamine to a weekly basis. And then I remember her saying, okay, I think he needs it twice weekly now. And that is my kind of decision time point that actually we've done enough. We've gone as far as we can with this case.
Sure.
So really my experience started with that one case and then a lot of experience over the previous years. And yeah, based on that experience, the recommendation is half a mg per kg on a monthly basis. And I would always say work out those caregiver reported outcome measures and make sure that what we're doing is actually doing
Yeah.
something. We have just finally got ethical approval for a study looking at subcut
Oh,
ketamine.
wow,
So we're
cool,
gonna have a devised a protocol for the study, and that will be starting hopefully not too soon in dogs with arthritis.
cool.
Yeah,
Okay,
we should actually be able to put some science behind the suggestion there. So
amazing,
yeah, my tip: off the gig, monthly basis, look out. Is it work? Are we absolutely sure it's working? And adjust the frequency according to the dog.
cool.
You said neuropathic pain there. I mean, obviously, a lot of our dogs are osteoarthritic, musculoskeletal pain, whatever, but there is a component that's neurosensitization and things. Is this only relevant if there's nerve impingement in the spine?
No, well, that original dog had lumbosacral disease, and I think we have a combination of nociceptive or inflammatory pain and neuropathic pain in lumbosacral disease, and I think part of the challenge of that presentation is it's really variable. I think even if you have an MRI diagnosis, and okay, you have a lot of dogs that have sensitivity over the LS region. Even when you have an MRI diagnosis, we're not always sure: are we treating nociceptive pain? Are we treating neuropathic pain? As well as that case that I've got probably most experience of using subcut ketamine in arthritic patients. Yeah.
Yeah. And for any vet students or sort of new grads that might be listening, where, I mean, maybe they know a lot more than I did when I qualified, but in terms of when you're talking neuropathic versus other pain, what do you mean when you talk about those different types of pain, nociceptive pain, etc.? What do you mean between those two differences?
So thinking about pain, sometimes we have to simplify things a little bit, and I think don't tell me I'm wrong for trying to oversimplify things from an explanatory point of view. The International Association for the Study of Pain has three broad definitions for pain. There's nociceptive, there's neuropathic, and there's nociplastic pain. And nociceptive pain is where we have pain caused by inflammation. So trauma, acute surgery, arthritis pain, all of those would be classified as nociceptive. Where we have neuropathic pain, we have a lesion or dysfunction of the somatosensory system, and that can either be peripheral or it can be central. If you think about things like Chiari, syringomyelia, examples of centralized pain, of central neuropathic pain, and peripheral neuropathic pain might be spinal, it could be nerve root compression, it could be a brachial plexus tumor, something like that. So those are our two most common categories of pain. And when I'm evaluating a patient, I'm trying to think, okay, do I think this is nociceptive pain or could there be a neuropathic element here? And often this is where the history and talking to the client is really important, and understanding the disease and trying to get a diagnosis where possible. Inflammatory pain, we've got constant dull ache, that pain of arthritis. In neuropathic pain, we have sudden onset, sudden offset, what's described as paroxysmal pain. So burning, shooting, stabbing is how it's described in people. I don't know if anyone listening has ever had sciatica. Ticks all of the boxes, really quite horrible. If you see the dog, all of a sudden they turn around and they nibble at their limb, or they might be sleeping in their beds and all of a sudden they react, jump up, or you have some clients that say, my dog goes in the garden and they just freeze and she doesn't know what to do. Those might be cases where I start to suspect that there's neuropathic
Okay.
pain involved, that sudden onset, sudden
Yeah.
offset. So yeah, history taking is really important in those cases as well.
Yeah. That's really interesting.
So a lot of us hear neuropathic pain, we think gabapentin, and
Yeah.
obviously, well, you mentioned the Chiari malformation, kind of
Mhm.
cavaliers, and they're often on pregabalin or whatever. Can you also there's a role here potentially for subcut ketamine in those
Yes.
Chiari cases?
Yeah, potentially. And I did a podcast last year. We got the Zero Pain podcast, and I did a podcast with Claire Rossbridge.
She's amazing,
And
isn't she? She taught
that
me my neuro at
I
uni.
love she's
Yeah,
brilliant.
she's so
yeah,
good.
you don't need to say much as a podcast host with
Yeah.
Claire because she just if you want someone on your chatty podcast who's chatty, then Claire's great. We talked about her neuropathic pain guidelines and she's got a treatment algorithm for syringomyelia and Chiari malformation. And that was published on her Neurovet website, but she's become a YouTuber. So there's a lot of Claire's information on YouTube videos as well. And ketamine is part of her treatment algorithm for those difficult cases, syringomyelia, where they're poorly responsive.
I've got so many. I was going to ask one on gabapentin dosing. Do you want to? Are you going on to another topic? Or are you still
But yeah, let's talk
on
about,
the gab?
yeah. I think
Because yeah,
I
go
think
on.
my big message Yeah, my big message to that community is we're going too hard with the gabapentin. Back off. back off, back off.
Yes, yes.
And think really, I don't think it takes me a long time to introduce gabapentin for an arthritic patient. It's definitely not a first line. It's definitely not a second line for arthritis. Yeah, we're going too hard. We're giving gabapentin, and all of those patients are getting sedated, ataxic, and the clients
Yeah,
think they're getting worse. The
yeah.
number of patients I've seen that are arthritic, and I stop the gabapentin, the client goes, "Oh, I thought it was his arthritis getting
Yeah.
worse," and it was actually the gabapentin. Start low and titrate up. So 5 mg per kg twice a day. Make sure the patient can tolerate that, and then titrate up. And if I'm finding with gabapentin I need to use more than 10 mg per kg TID, then I'm thinking, hang on, I need to be doing something else. I very rarely use more than that. But I have seen cases where the dogs are happily using 20 mg per kg of gabapentin 3 times a day, and it is controlling their pain. So you will get some every now and again, but that is definitely not a part of my routine repertoire, I have to
Because
say.
didn't it used to be in the formulary? It used to be between 10 to 60 mgs per kg, didn't it? Written in the formulary.
Yeah, it's a
Yeah, so
monster.
I think people used to think,
And
"Oh,
that
it's
comes from
fine."
the anti-epileptic. Yeah, and that's the really hard thing about formulary doses. I think the BSAVA formulary is better than other formularies because it breaks down, right? Use this dose for this, use this dose for that. But yeah, a dose range of 10 to 60 mg per kg is use to
Yeah.
nobody. So you definitely got to specify where to go in that. And yes, we do spend a lot of time clarifying that with people for sure.
Charlotte, as an emergency vet, I used to get this so often. Day 4 or 5 of the gabapentin, I'll get the phone call from the client, and as an emergency, dog's gone off their
Yeah,
legs.
yeah.
And then,
Yeah.
you talk to them and, oh, no, they started the gabapentin 5 days
Yeah.
ago. You're like, I think that's probably the
Yeah.
problem.
Oh,
You're
you had enough.
Yeah.
okay. Yeah.
Yeah, they look like they've had a
Yeah.
bit too much alcohol. I wanted to ask you, Matt, in terms of subcut ketamine in arthritic patients, obviously we go for a multimodal approach with these guys, and there's lots of different drugs that we can consider. Where would you recommend to GP vets that are treating arthritic patients? Where would you recommend that that gets added in? Do you see it as like a last resort analgesia, or do you find that it should be added in a bit earlier, or where do you see it sitting in the protocols?
Yeah, good thought. So we have our first line analgies. Arthritis, we have 3 classes of drugs that are licensed. I sound like a broken record
No,
here.
you're fine.
We have 3 licensed drugs. We've got the non-steroidals, we've got grapipran. I say galliprant, it is different the way it spares prostaglandins, blocking the EP4 receptor. I don't feel it's fair to lump it in with the non-steroidals because it does have a slightly different mode of action, which is why I say 3. And we've got bedavetmab for dogs and freenavetmab for cats. All of those 3 are licensed as first-line analgesics for osteoarthritis. So we should really, let's say we try non-steroidals and our non-steroidals aren't effective, before going up the ladder and going off license, we should try one of the others within that licensed option. So let's say we have done that, our arthritis is progressing. When we've got progression of arthritis, we've gone from that disease causing sensitization in the periphery to very much likely causing central sensitization. We hear this referred to as wind up. I'd say it's a kind of lay term. The purist would say that's a laboratory phenomenon and you can't say a patient's got wind up. Anyway, we understand what that is. When we have that widespread sensitivity and central sensitization, we need to think about how we can target that. And one of the key receptors involved in central sensitization is the NMDA receptor. So we think about NMDA antagonists. That's where amantadine comes in. And we've got the study from Lascelles from 2008 or 2007, around about that time, which documents when you add amantadine to meloxicam, you improve activity and improve comfort levels in dogs. Beyond that, we don't really have too much information, but options, we have amantadine, we have memantine, both of those off license, and then we have ketamine as an NMDA antagonist. Now, clearly, if you're deciding between those 3, we have one paper for amantadine in dogs, we have one paper for amantadine in cats, we've got no papers for memantine, we've got lots of experience with memantine, and right now we don't have any papers for ketamine. So if we're saying, right, we want to practice evidence-based medicine, we should really reach for our amantadine. We know amantadine is really expensive, and memantine is significantly cheaper than amantadine. So I have that conversation with clients and say, this is the situation. I would reach for amantadine, whether memantine is a lot cheaper. In my experience, it has a similar effect. I'm still kicking myself for not having written any of this in the literature for the past 10 years because I've been using lots of memantine, and I enthusiastically think I'll write something and then I submit with the publication and get really disappointed because it's such a challenge to get anything
Yeah,
published
yeah.
ever. Yeah, NMDA antagonist is the second line, which is where I'm not reaching for gabapentin in that situation. I'm using the NMDA antagonist as part of what I do. And I tend to find that in those cases, I mean, again, coming back to the examination of that patient, and that arthritis pain is breaking through what our non-steroidals or our other first line analgesics can do, we have widespread sensitivity. We've got sensitive muscles. Make that part of your outcome measure. Feel those muscles the next time they come back in after you've started them on amantadine or memantine, and you will find that those muscles are a lot more comfortable. So yeah, that's definitely something that we see, and that's the feedback I get from my physio colleagues as well.
I think I can probably speak for a lot of GP vets when I say that I see a lot of people for arthritis management in dogs where people are using an NSAID or something like Librela as their first line, and then they might add in something like amantadine maybe second. But a lot of people are also reaching for paracetamol quite regularly in these patients alongside your gabapentin, etc. Do you think paracetamol has a place in these chronic pain patients? Do you think it can really help, or would you be more conservative with how often you're using it?
It's an area where we really need some more
Really?
evidence. There's more evidence building for paracetamol in the acute
Mhm.
setting, and that literature is becoming more convincing, but there's a real lack in the chronic space. However, I think a number of us have cases where those dogs definitely respond to paracetamol. I had one this week. This is a dog she's got lumbosacral disease, and there's a question over how comfortable her hip is. So we're waiting for a hip radiograph on her. She's got behavioral presentations as well, so she resourced guards. And you talk to the clients. This is a dog on multiple analgesics. You have a conversation, and a lot of what I do with chronic pain patients is reviewing the meds they're on, asking the clients, right, what made a difference? When you added this, did it change the whatever outcome? And these clients thought, oh, we're not quite sure whether the paracetamol made any difference. This dog's on Pardale. And so we stopped it. And that the dog did go backwards in her behavioral presentation as a result of that. So sometimes we don't know the paracetamol's doing anything until we actually stop it. And that's been reintroduced. And within 3 to 4 days, that's making a difference for that dog. And so it is that experience that says to me, yes, paracetamol does work.
Yeah. And when you use it, do you go the crazy Pardale dose, or are you going like 10 mg per kg in these guys, and how often?
Glad you
It
brought that up.
Yeah.
Yeah.
And the honest answer is we don't know because the Pardale dose, I can't find the licensing
Yeah.
studies from Pardale. They
Yeah.
don't exist. Um, no one's ever gonna go back and relook at that because if you were to do a study and prove that it doesn't work, then the VMD won't be very happy. They'll probably take the license away from
Yeah.
Pardale. So that is the long and short of it. And still, I used to say, oh, we probably need to be using close to 20-25 mgs per kg, but I still don't have any evidence
Yeah.
to bet my house
Yeah.
on. But I use 20 mgs per kg TID is the dose I use. There is some,
Long-term dose, yeah.
yeah,
Yeah.
long term. And really, what I would say is, okay, start with 5 days of Pardo. It's licensed. That's what we should do. And then afterwards, it's off license after 5 days anyway. So it doesn't really matter what you do. What we definitely shouldn't do is just tell the client to go and buy it from the chemist because the VDS are very clear that we are not covered if we give that level of advice. So the way we got around that, where I worked previously, we had generic we had all the paracetamol options. We had Pardale, we had the Bova preparation as well, which is really convenient. We did have human paracetamol as well. We just sold it for a very cheap price rather than we put any markup on it. So we can say that we are prescribing it because otherwise the clients just look at you and they say, okay, I'm going to prescribe you paracetamol. It's going to cost you over a
Yeah.
tenner. They're not very happy. That's
Yeah.
my recommendation around that
Yeah,
one.
it's interesting that you use that dose long term in terms of tablet dosing because I mean I regularly use like 20 mg per kg in my IV infusions of paracetamol, like in surgeries, etc. But I've never quite been brave enough to go much above 10, 15 mg per kg in terms of long term tablet dosing. So that's really interesting that you say that, and especially TID still. So I mean I know we need more evidence, but it's nice to know that someone that knows what they're talking about is using a very similar, which is cool.
Yeah, so I think it's fine to start with your 33 mgs per kg TID for 5 days. And then, okay, sometimes I don't honestly know where to go from there. So I do go to 20. I very rarely use less than that, though. This dog I'm talking about is on Pardale. She's on about 22 mgs per kg of Pardale from
Yeah.
memory. What I would always say is if you If you reduce the dose, just make the client aware you're doing
Mm.
that, and if you lose analgesic capture, then it's the right decision to go
Yeah.
back the other way.
I think I had a brainwave and because you were talking about ketamine every month and you're saying about using it when you got central sensitization. And I thought, when you're seeing your Librela cases every month for to their injection, would it be really terrible to also give them a little half a mg per kg ketamine?
It's a very common approach, I would say. I think you see those cases with Librela where in the 3rd week, the effects just starting to
Yes.
wane. And
Yeah.
my first advice around that is just check the dose, because the dose range is half to 1 mg per kg. And if we just go off the dose chart, some of those dogs will be on half a mg per kg, and that's not quite enough for them. And I would always increase them up to the next vial size so they're closer to 1 mg per kg. Um, I always suggest. I read in a history the other day. I'd suggested that to someone, and then they said we've done that and put off license in brackets. I was like, no, 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 it's not off license. It's still within the dose range. It's just not on the dose chart. And you often find that if you look at the actual dose of drug on the data sheet, the chart will be at one end or the other. Yeah, first advice for those cases is to optimize the dose, but then yes, you can add in the ketamine on an as required basis. And I've seen plenty of dogs where that works really effectively.
We sort of touched on the big controversy that came up about Bed and Vet Mad Librela last year and the sort of papers that came out, etc. Are you still using it? I mean, you might have to be a bit careful what you say, I'm not sure. But are you still using it fairly regularly in your chronic arthritic patients? And you say you're still considering it a first-line analgesic in these guys, even young patients, or
The beauty of zero pain is we're totally independent
good?
and are not influenced by anybody's.
Oh, good.
Our whole aim, we look at the literature, we take an evidence-based approach. They've written a monologue. It turned out to be 5,000 words, the Librela story.
Yeah.
Every time a paper's finished, I go, oh, I need to go back to it, and I do need to go back to what I wrote. That's on the pain news section of our website, and I wrote that in August last year. So there have been some developments since. Where are we? There is definitely something going on with musculoskeletal adverse events with Librela in a small proportion of dogs. So when you look at the adverse event data, that is still classified as very rare based on the reports that are being made at the moment. And okay, we have to bear in mind that all adverse events are underreported, so we don't really have a true idea of what the adverse event rate
Mm.
is. The adverse event rate and what we're seeing with Librela, I would say, is no worse than us prescribing a non-steroidal and then one in however many dogs getting a duodenal
Mm.
ulcer. So that's what we're talking. I think there's this concern around Librela. Oh, I can't prescribe that. I'll go back to my non-steroidals. But actually, that isn't. There are lots of evidence. There are lots of things we can say. Right, okay. Are you truly taking an evidence-based approach in how you're managing these patients? To be fair to, I think we have to be fair to the product. I think the frustration initially was that there was not really a recognition that there was a
Mm.
problem, but there seems to be more of a recognition now from Zoetis that yes, there is something going on, and we are keen to understand what that is. I don't agree with the people that are calling it rapidly progressing arthritis, because it's not. That's a human term. When we diagnose when a new disease is noticed, you start by describing it, and RPOA is not the right term. There is something going on. There is no argument about that. But what is going on needs to be described clinically and radiographically. And then there needs to be efforts to document, okay, is this dose related? Because it could be dose
Mm.
related. I don't think there's enough understanding to say which patients you shouldn't use this in. Because I've heard people say, I would only use Librela in old dogs, I'd never use Librela in young dogs. We don't have enough information to say that at the moment. So we are in a kind of unknown area. What do I say to clients? I think we now have to say to clients that this is a potential adverse event that could happen, but it is very rare. The more common adverse events, the top three are polydipsia, ataxia, and lack of effect. If you look at the data, so those are the things that we should be listing first. And they're saying in some dogs there can be I think musculoskeletal adverse events is the easiest way. It's not really is there muscular involvement? It is more skeletal, the lesions that you do see.
Mm.
I think we have to talk to clients. And we all know we've had clients that come into our consult room and say, I don't want my dog to have Librela. I'm not going to try and convince that client out of that decision. And I've had clients that say, well, my last dog had Librela and it made a massive difference. So I want this dog to have
Mm.
Librela. Yeah, it's that kind of patient-centered care. It's having a discussion with the client and working out what's the best for the patient. And I have had patients where, for whatever reason, the client says, yes, I want to use Librela, and
Yeah.
I'm quite happy to do that.
Yeah. And do you think we can sort of safely make the same assumption that we are, as more evidence comes out, we are likely to see some of these rare events in cats as well that we're putting on Silencia? I mean, do you think we are likely to see much of the same as well? I mean, that you have people come in after you've started them on it and they say they're like a kitten again. You know, it makes such a massive difference, which I think was such a shame when this paper came out that everyone panicked and, we're taking dogs off it left, right, and center. But it would be really interesting to get, like you say, much more research into the area to say, okay, how worried do we need to be? Because I think the big media scare made everyone change what they were doing quite quickly when actually maybe it doesn't need to. So,
Yeah, I think there was definitely an overreaction there when you look at, and the message that Zoetis are giving is look at all of the millions of dogs that are
mm,
benefiting from this product, and you are denying those dogs effective analgesia. And we all know, I mean, I've worked with dogs, so many arthritic dogs over the years, where we just hit a limit with our non-steroidals, we
mm,
hit a limit with our NMDA antagonists. You then give those dogs Benenvetmab, and they're a different dog. So we have struggled through managing dogs over the years, and then this very effective product comes along, so it's hard not to. Cats. I have seen one case in a surprise, it was a vet's cat. This was in 3 months of Silencia being launched. She injected her own cat. I think the cat had 2 doses of Silencia and developed a lesion on its hock, which looks like a kind of starburst lesion on radiographs. And at the time, okay, the product had just come out, so it wasn't something being reported. It's like, well, okay, that must be something else. It can't be associated with the product because it just wasn't
mm,
reported. But the old retrospectoscope, I'm sure there was something to do with the Silencia there. I wonder if I don't know whether cats react slightly differently or whether it's just that there's far more Librela used out there than there is
mm,
Silencia, and that's why we're not seeing those. The adverse effects we're seeing with Silencia, the worst ones are the skin related adverse effects that you see in
mm.
cats. And there was a
What's that? Yeah, is it like allergic skin or different?
Yeah, there is a paper, and I can't remember. I think it's an Australian group that published it. It's a case of 5 cats with dermatological reaction. So this was something that was noted. There were 2 trials. They noted skin reactions in one of the first studies, and that paper was like, "Oh, okay, fine, we saw this, but we probably saw a similar number in the placebo group." And then it was documented in another study. And then when the product was launched, there were cases reported of skin reactions in cats. And I had one in, again, surprise, surprise, nurse's cat, where she developed it was a lesion about the size of your thumbnail, which you'd call a hotspot. You'd look at it and go hotspot, but hotspots in cats are really weird. You don't see hotspots in cats all the time. I remember seeing them in dogs all the time, but it's very rare in cats. And we stopped the Silencia in her. This was a cat, arthritic cat, treated with meloxicam, had iris stage 2 kidney disease, so naturally keen to use something that's not going to make the kidneys worse. Responded really well to Silencia, but she developed that lesion, stopped the Silencia, put her back on meloxicam, and that lesion did resolve, but her comfort wasn't as
Mm.
good. I had a discussion with the nurse. We did restart her with Silencia, and she didn't have a second
Ah,
reaction, which was
yeah.
interesting. But I've
Mm.
heard of cats with worse skin reactions than that, and we don't quite know why it happens. You can get in people a peripheral neuropathy. So my thought process is if you are a cat and you get a peripheral neuropathy and you get tingling somewhere in your body, what do you do as a cat? You groom,
Mm.
you lick, you overgroom. I don't know. That's just my school of thought that there's a tingling in the skin. The cat doesn't like it. They start licking at it and develop the lesion.
Yeah.
I think the only case I've had negative, side effect from a Librela in a dog was, it was a 7, 8-year-old dog, and it had no history of ear or skin, no skin problems at all, no allergies, and it was bilateral flank. Well, I thought it was pruritic and, can't I think it was getting lesions, like maybe erythema and things on bilateral flank kind of area.
Okay.
And that the owner I chatted to the owner, he said he went onto the American vet site, for Librela, and it said it was the commonest side effect or something. And I looked in the data sheet in the UK, and it's not there at all.
But it's definitely not, no.
No, okay, good.
They are listed. I'd have to look back. There's a bar chart. Beatrice Montero published something last year looking at the adverse effects. That's where those top 3 that I reeled off. I don't know where, I can't remember where skin disease might have featured on
Yeah.
those, but yeah,
But the
interesting
guy,
one.
yeah, interesting. The guy, he said, I'd rather carry on with it because it's so amazing for the dog's legs that he'd rather have the skin problem as well. I was kind of
Yeah.
quite shocked because it's, yeah.
Yeah, and I had loads of clients where the dogs had either polyuria or polydipsia. Lots of clients said, "Well, my dog's so comfortable, I want to carry on with it anyway."
We've been chatting a little bit about cats anyway with Silencia, similar to how we were chatting about
Mm.
dogs and your steps of what you'd use in terms of chronic pain management. In cats, we tend to have a little bit less sometimes to play with. If you've got a cat on meloxicam or Silencia or both potentially, and you still feel that they're getting breakthrough pain, are you reaching for subcut ketamine in these guys, or are you going for something else that you would use first, like your gabapentin potentially, or what's your sort of steps in your chronic pain for cats in their management?
Yeah, so interesting. There are 3, well, there are 4 studies. There's one looking at gabapentin, one amantadine, and 2 tramadol. And there might be, if I've missed something in the past 3 months, that is entirely possible because I haven't looked at the cat literature in the last 3 months. But the commonalities with the studies, really small studies, so you're talking 10
Mm.
cats in each group. They are mostly placebo controlled. The amantadine was versus placebo, and that was cats treated with just amantadine, not amantadine meloxicam. They showed an improvement in quality of life in cats given amantadine. The dose they use, I can't remember, the range is 3 to 5 mg per kg. I think the range is 3 to 5 mg per kg. And the most common adverse effect was sedation. And that probably is dose
Mm.
related. So again, I'd probably go 3 mg per kg twice a day and maybe just start 3 mg per kg once a day and titrate up if you think you need to. So bear in mind, small study, but there was a positive outcome for those cats with amantadine. Similar study with gabapentin, that was 10 mg per kg twice a day. So again, they did report that sedation was an adverse effect. So I would go back to 5 mg per kg twice a day and titrate up. And what was the third one? Oh, there were 2 looking at tramadol. And one of them showed that tramadol was effective in cats, but the problem was that the products that they were using was really bitter, so it's hard to get into the cat, which I think is our familiarity. What I have done, I tried in one cat, was using Traleve tablets and splitting the 20 milligram, the smallest size Traleve, because they're palatable. So I would say if you have a cat and you're really struggling, I would try Traleve because, again, you could look at the evidence and say, well, the evidence is fairly equal for amantadine, gabapentin, or tramadol. And then the question is, well, which is easiest to get into the cat and which is most effective? I think the way I normally think about prescribing as well is, okay, we want to prescribe a drug. We want to make sure that it suits the patient. So I tend to just prescribe a week. If I was prescribing amantadine to a cat, right, I'm going to prescribe a week. Just give me a call. Let me know if it suits the cat. If everything's okay, I'm going to dispense another 3 weeks and I'll see you a month after that initial diagnosis because we need a month to work out whether that's really working. It takes time. We know it takes time to wind the pain system back down again. And that's a very broad statement, but we definitely know from studies looking at non-steroidals, Galliprant, and the licensing studies for the anti-nerve growth factor drugs that it takes up to 6 to 8 weeks for full effect with all of those classes. And I don't think that's the drug necessarily getting into the system. It's the pain system correcting after providing analgesia. So new prescription, make sure it suits the pet, and then give another 3 weeks, and then we'll see them back, look at those caregiver outcome measures, see if we're having an effect. If the answer to that amantadine prescription is absolutely, it just didn't make any difference to the cat at all, then I would go down the same route with gabapentin and go down the same route potentially with tramadol. And then somewhere within that, you may think, is subcut ketamine an option? Depends on the cat. Can the client get the cat to the vets on a regular basis?
Yeah.
Does the cat like injections? Do they coming at home? So yeah, different kind of compliance considerations to bring in there as
Yeah.
well.
And if you're going for subcut ketamine in cats, are you sticking with, I know again we don't have true evidence for it, but again you're going for half a mg per kg, are you, in these guys?
Yeah, I do. And I had a very old skinny cat. He had IBD and something else. I used zero point 0.3 mg per kg in him and it seemed to work. I just thought, those old, slightly dehydrated cats. I thought, I'm just going to lower the dose to you. It ends up as an absolute micro. You need one of the half-size insulin
Yeah.
syringes to deliver it. But
Yeah.
yeah,
Oh,
it,
cool.
it, it was effective for him.
Cool.
We got so excited about chronic pain management. We've got like questions on so many different things, and that was just so interesting. We didn't go off
No.
topic.
Yeah. Well, one thing I wanted to mention to like lead on from the chronic pain discussions we've been having, because I think maybe we stick to chronic pain for today because it's all we've harped on about. But
Mm.
Mm,
we actually had a
yeah.
chat to, I don't know if you know about him, we had a chat to Russell Chandler recently about regenerative medicine. And it sort of really enlightened us both because we both had been, well, I definitely was in the pool of regenerative medicine was this like fanciful thing that nobody really knows that much about yet. And, people have heard about like stem cell therapy and platelet-rich plasma and all that sort of stuff. But I don't think many people who aren't orthopedic surgeons, etc., are really playing with that sort of stuff yet in general practice. So from zero pain point of view and in terms of chronic pain management, arthritic cases, etc., are you trying to work hand in hand with regenerative medicine? And do you think it really makes a difference in terms of these chronic pain patients?
Yes, absolutely. And we did a great podcast with Russell as well
Hey, there we
earlier in the
go.
year. So we should definitely think. I mean, the whole problem with osteoarthritis is we are diagnosing too late, mainly because we are presented with those cases too late. So if we look at the COAST guidelines, the canine osteoarthritis staging tool, splitting into preclinical mild, moderate, and severe arthritis. I think most of the cases we're seeing are moderate and severe. And if in those mild cases we ask the question, right, okay, actually, it probably is the right stage of the disease to be using stem cells in a regenerative approach here, we could potentially manage that case for a lot longer before their arthritis progresses. That is the holy grail of arthritis, is saying, right, we have a treatment that is going to slow down
Mm,
progression. And really, until now, we haven't had a great understanding of how fast arthritis progresses. And actually, that's one of my things to come back to when we talked about rapidly progressing arthritis. There are dogs whose arthritis progresses rapidly, just as there are in people. So there is some evidence building from the University of Montreal that there are dogs where the rate of progression differs. We don't have predictors of that at the moment. And we all say to our clients, okay, the arthritis is going to get worse. How bad is it going to get? I don't know. When's it going to get worse? I don't know. But the best hope we have, to my mind, is getting in there early with some of those regen options. So yeah, I'd say early recognition, early diagnosis, early treatment. If you had a client that was saying, right, okay, what is the best thing for my dog? I would be recommending regenerative, definitely.
yeah, cool. I think we were properly enlightened when we had the big chat to them about it because I think it's something that it can definitely make its way more into general practice, especially your PRP. I think that can be used so much more often than it is. And yeah, it was just really interesting because I think we all think about all the medications that we can use, but we don't often start thinking about what we can do to slow the progression and to get in there early, like you say. So yeah, no, interesting. So do you have any other particular questions you want to throw out, Brendan?
No, I'm thinking we need to book Matt again. I'd love to do another hour, another day.
We can, that's fine. Yeah, we can make that work. If, it,
Yay!
if anyone has any questions in the meantime, I say everything is on zero pain. One of the reasons we created zero pain philosophy in the first place is because we went and delivered lectures to people, and you have a great conversation, and maybe people take away notes, and then your notes sit somewhere, they change.
Yeah.
We just update the website. When something changes, we update it on the website. You don't have to worry about dusting off your notes that then go out of date. The pain news section is free to access. So whenever there's something new happening in the world of pain, it's on there. So all of the topics we talked about tonight, there is either a post or a webinar or a podcast to go
Yeah,
through.
great.
So
And you have
yeah,
like a,
yeah.
a membership section where people can sign up and get more CPD lectures, etc. Is that right?
Yeah, we do. So the free bits are the pain news section and the podcasts. And then the bits that you sign up for are our webinars. So you can buy an individual webinar. So if you want to listen to the subcutaneous ketamine webinar, you can buy that as a one-off. And then the membership options are a monthly payment or an annual payment. So the annual works out a little bit cheaper on a basis. And there are different rates for vets, nurses, and vet professionals, new grads. There's a student rate. The student rate is £10 a year. Yeah, we kind of cater to we've got a low middle income category because we've got a global reach. So yeah, we've catered to all options there.
Well,
It's amazing what you're doing.
yeah, absolutely. And, thank you so much for coming on. We really appreciate it. And I think that the people that listen to the podcast will, I think, have really, really enjoyed that. So I know we did. We were both like very engaged.
I know. I
Yeah.
was like, I was free for CPD. I was making notes while you're talking. It's great. Loved it. I have actually got one more clinical question, and I have to ask it because someone on our social media comments mentioned it, and I thought, what a cool idea. And I thought I'm going to ask you about it. Tiny bit connected, but not. You know, we were talking about co-induction. She said that they co-induce with maybe it was 1 mg per kg of ketamine with the induction agent. And I thought, well, that's kind of clever. Yeah, are you on board with that?
So the whole idea of co-induction is that we spare the original drug we were using and we avoid all the adverse effects. So we don't like post-induction apnea. If you give 1 mg per kg of ketamine IV, you're probably going to get post-induction apnea. So to me, it defeats the object. If you're using ketamine, it completely defeats the object. We should definitely include ketamine in our anaesthetic somewhere if we've got a painful patient. I just give it IM.
Right.
I don't
Okay.
co-induce. I give them the ketamine IM so they get the benefit of the ketamine.
What dose are you using? Are you
Okay.
going 250 or 500 micrograms or?
1 or 2 mgs per kg
Okay.
for an IM dose. Yeah, and if I need to use ketamine for a rescue during surgery, let's say heart rate, blood pressure, everything's settled, suddenly they react, the best option is an IV option at that point, and I'll use half a mg per kg, but you will get apnea associated with that. So this is something that I talk to lots of people and they introduce it into their practice just for things like bitch spay. And it's a case of working out when is the best time for you and the way you practice. Is it best to trickle it in slowly, half a mg per kg when you move into theatre? So by the time you drape and the surgeon incisors, there's no reaction. You give 1 mg per kg IM or 2 mg per kg IM as you're prepping, and then when you're in theatre, you've got that effect. You can just, it's a case of working out what works for you. So yeah, half a mg per kg IV or 1 to 2 mgs per kg IM. Play around with the timings and find out what works in your situation is what I say.
Perfect. Cool. Yeah, great.
So it causes apnea. Is that what you're saying? It is.
Yeah, so
I
ketamine
didn't
does.
know that. Okay,
Yeah,
that's so cool
even
stuff.
half a mg per kg. You see, if you've got a capnograph, we'll see your end tidal CST. It might have been 35, 45. It will go up to 50, 55, 60, and your rest rate will slow down. And in some cases, you will get apnea, which is fine because we've got a rebreathing bag. We can give the patient a breath, but it's not fine if the person monitoring the anaesthetic doesn't know to expect that.
Yeah.
You will get a very unhappy nurse.
Well,
Cool.
thank you so much, Matt. Again, we really appreciate it. And fingers crossed, yeah, we will get you on at a later date. We'll start talking about some other bits and bobs in terms of pain. And would it be okay if anyone has any questions or comments, if we can send them your way after the pods come out? Because people might have some questions directed to you.
Absolutely.
Great. That'd be cool. So
Yep.
perfect.
Sounds
Thank you
good.
so much.
Cool.
Awesome.
We love that. And you can probably hear the fangirling in our voices. We were so happy. We had a really, really good conversation with Matt, and we hope you really enjoyed it.
Yeah, it's brilliant. I really hope we can do it again. We're super keen to hear your feedback too about this interview. You know, the protocols that you find effective for your chronic pain arthritic patients. Do you use paracetamol and gabapentin really often? What doses are you using? I think paracetamol 20 mg per kg seems to be more common now. It used to be 10 or 15. Do you think what you've heard today might change what you do? That would also be
Yeah.
interesting.
Yeah, absolutely. So please do get in touch and let us know what you think. Send us your voice notes via WhatsApp or message us on social media. Or remember, you can start a discussion with us on our blog. So we'd love to hear your feedback and comments on this topic, especially. So please do get in touch.
Absolutely. We'd love to hear from you. But for now, thank you for listening. Tune in next Sunday for our next 2-week takedown episode, where we'll be covering everything from neutering debates in cats and rabbits, we didn't forget them, and how you have those really tricky conversations about post-op complications, how to deal with complaints.
Yeah, tricky one, but we're looking forward to it already. Until then, it's bye from me.
And bye from me. Take care. This podcast podcast is intended for licensed veterinary professionals and is provided for educational and discussion purposes only. Whilst it's publicly accessible, it is not intended as advice for pet owners.
The views shared are based on our own clinical experience and interpretation and do not replace individual clinical judgment. We accept no responsibility for decisions made based on this content, and all cases should be assessed on an individual basis.
Any references to medications, treatments, or products are made for educational discussion only and are not intended to promote or advertise veterinary medicines to the general public. Veterinary medicine should only be used under the direction of a prescribing veterinary surgeon and in accordance with UK veterinary medicine regulations.
This podcast may include paid partnerships or sponsorships. These do not influence our clinical opinions, and any sponsored content will be clearly identified.